Hello and welcome to this session on advances in the management of childhood eczema. My name's Helen Brough. I'm a Professor of Paediatric Allergy at King's College London, and I work as an NHS consultant at Guy's and St Thomas's Hospital and the Evelina London Children's Hospital in London. I'm delighted to be giving this talk to you today on the advances in the management of childhood eczema, and I'd like to thank the conference organisers for allowing me to give this talk via Zoom. These are my disclosures. Essentially, I'm doing a trial which is looking at whether early proactive management of eczema can prevent the development of food allergies, and we have received some creams for this, and I'm also doing talks for DBV technologies. So these are all of the different things that we know can increase the risk of developing atopic dermatitis or eczema. There are various aspects here which I'm not going to go into in great detail, but there's air pollution, low vapor pressure, hereditary factors, which we know such as filaggrin, stress, itch, the itch that scratches, lack of immunological function or microbial dysbiosis, dysregulation of the skin barrier, and then ethnicity and how this presents in children and adults with different ethnicities. And all of this leads to financial burden, reduced quality of life, and increased issues with depression and various other mental health issues. So what can we do about it? Well, the good news is that there is a lot that can be done, particularly with getting the basics right. So I'm going to focus quite a lot on education and skincare. Then I'm going to talk about topical anti-inflammatories, microbial therapies, some new data on allergen immunotherapy, particularly with reference to house dust mite, and then I'll touch briefly on systemic therapies. So what about education? So we know that children who come to clinic and their parents have received many conflicting pieces of information, such as how often to bathe, what creams to use, what temperature to use, all those different things. And we at St Thomas's Hospital have done very successful multidisciplinary group education, and we have shown that this improves atopic dermatitis outcomes for children, and this has been very effective. But it is expensive to run. We need the rooms, we need the eczema nurses, and it is time consuming both for the staff and for the parents bringing their children to these sessions. So online interventions are preferred as long as they are engaging enough to maintain people's interest. And this is where the NIHR funded a really groundbreaking tool for parents and children with eczema and adults with eczema called eczemacareonline.org.uk. And there are many of these around the world, but I have had the opportunity to look at this particular website and see how good it is. And also there's been some research using this tool that's shown sustained benefit of AD severity over 12 months in children and young people. So, what does this show?
Eczema Care Online is an interactive website to help people live well with eczema. It was developed by parents and people with eczema alongside world-leading experts and is based on the most up-to-date scientific evidence. There are no adverts and it is free from any commercial influence. The result? A unique, freely available website with everything you need to know about eczema. Eczema Care Online is for everyone with eczema, from babies to adults. You can choose to look for myself or my child to make sure you get the right information. There are videos, lots of top tips from others living with eczema, and tools to help you get control and keep control of eczema. Eczema Care Online was tested in 2 large studies with over 650 parents and young people. We found that those who had access to the website had significantly better eczema after 6 months and after 12 months compared to those who only had their usual healthcare. The Eczema Care Online Toolkit is free for anyone to use and no sign-up needed. You can find it at eczemacareonline.org.uk. Find it, bookmark it, and share it with friends or family to help get control and keep control of eczema.
So I hope that this is helpful with regards to this particular website, which I would highly recommend, and there may also be some other websites that are available locally to you that are available in different languages as well. What I also find to be extremely helpful is to have leaflets in my clinic that I then hand out to parents. This particular leaflet is really good because it addresses some of the concerns that teenagers have. And they want to be able to live their life and not have to worry about their eczema. And it's all about trying to motivate them to use the treatments that you know will work, which is acceptance and commitment therapy. And this essentially will enable them to live a full life. And also, I like any information leaflets that have visuals because I think it's so important for people to see this. In this particular one, it shows that if you are using an ointment, it is extremely important that you use a spoon or a spatula to take the ointment or cream out of the pot so that no hands are going inside the pot, as otherwise the bacteria on the hands, even if hands have been washed, stay in the pot and they proliferate. And then this leads to increased risk of Staph aureus, infection in the skin, and we know that that makes the eczema more severe and also has wide-ranging impacts for food allergy persistence, development and severity. The other thing is the preference, because of the risk of putting hands in the pot, for a pump, or I would also say a tube, and then the importance of applying the moisturizers in the right way so that you don't irritate the hair follicle. And then the other thing I found very helpful is that in young people, there are many questions that they have that they may not feel able to ask about, such as the oral contraceptive pill, having a relationship, going to university, drinking alcohol, all these things that they need to have information about that you can provide in a written format. And these are leaflets that I get from the National Eczema Society in the UK. They're free, and there may be a similar form of charity in your locations. So this is a review that I did with some collaborators looking at the different aspects with regards to the management of eczema. The first thing we know is that the three main areas of eczema are a disrupted microbiome on the skin, dysregulated and broken down skin barrier, and then a pro-allergic inflammatory cytokine milieu. So with regards to the skin microbiome, we know that the children that have eczema and adults have much more in the way of Staph aureus colonization, and this then drives reduced microbial diversity on the skin, and it reduces commensal bacteria as well. And then what happens is that you also have an increased risk of other types of pathogens such as Malassezia because you're lacking certain antimicrobial peptides that help with this. And then children are much more likely to develop impetigo or even eczema hepaticum because they're unable to fight the infections on the skin using the innate immune system. Skin barrier disruption, we know from following the landmark discovery of the filaggrin gene, and that having a mutation in this leads to having more porous skin, reduction in certain products such as natural moisturizing factor that maintain the stratum corneum. We know also that the skin pH is then raised and you have increased amounts of proteases and reduced ceramides. The transepidermal water loss is raised because you are losing water, which means you get dry skin, and then that means that things can get in as well. And you can have the lipid bilayer and fatty acid chain length disorganization, which we know, for example, that certain oils can also make worse, such as olive oil. Then we know from the inflammatory cytokine perspective that we have predominantly IL-3, IL-13 and other Th2 cytokines, which is why dupilumab has been shown to be so effective for eczema. And then we have other pro-inflammatory cytokines such as TSLP, IL-31, which is a key component of the itch-scratch cycle and a primary driver of pruritus, and then IL-33 and innate lymphoid type 2 cells, which increase with skin trauma and may increase the intestinal innate lymphoid type 2 cells in the gut. And this has been thought to be one of the links between eczema and food allergy. So moving on to skin care, I'm going to talk about various emollients and which one might be best for your patient. It makes sense that having an emollient to moisturize the skin and to replenish some of the moisturizing factors that are missing from the skin will improve eczema control and reduce the needs of steroids. But many parents and children want to know which is the best cream, and is it a cream or lotion or gel or an ointment that should be used? And that's why this study was carried out in the UK, where they took 550 children with eczema between the ages of 6 months and under 12 years of age, with a median age of 4. And then they looked at POEM and EASY as ways to measure eczema severity. Then they randomized these children to either having a lotion with glycerol, which is a humectant, cream with no humectant or lanolin, which we know is a contact allergen, gels with no povidone, and ointments with no additives. And then they looked at the POEM eczema severity marker over 16 weeks. And what they found was that essentially there was no difference between these 4 different types of emollients. There was also no change in the skin appearance, quality of life, or eczema severity. However, there was a quite large rate of adverse events, mostly stinging, and that stinging was less common in ointments. And these are just the results shown in a slightly different way, showing the baseline score of eczema severity and that there was no significant difference between the groups, but that there was overall improvement from baseline to 16 weeks after using these different emollients regularly. So in my clinic, I do provide this moisturizer decision aid. So parents need to know what they want it to feel like. Do they want it to feel thin and light or thick and heavy? Do they want it to sink in quickly or slowly? Do they want to have to do it more frequently or less frequently? And how likely is it to mark clothing? Because ointments, of course, will mark clothing. I also find it's helpful to talk about the weather, and if you have a child that has eczema, it may be more helpful to do ointments in the winter time when it is drier, and perhaps creams, gels or lotions in the summertime. This is the next thing that I want to stress, and I know that there will be something like this locally to every hospital, country, which is a written eczema action plan. And this, I think, is incredibly important because I have seen in my clinic so many parents where we discuss all the ways to manage the eczema, but because in the clinic we talk about eczema, food allergy, asthma and hay fever, there's a huge amount of information, and actually managing eczema is quite complicated, and so a lot of the time the information that is imparted is not absorbed, and then they come back and they're doing different things. I've seen all kinds of things. I've seen most commonly that parents won't put anything on the child's face because they worry that the face can't be had anything on it. They will, for example, use the moisturizer only in the parts that they don't use the topical anti-inflammatories. I've seen that as well. So there are many ways in which they can get confused in terms of how things should be done correctly. So I would advocate that anybody who is seen in a clinic for their eczema should have some form of written information when they leave the clinic. Now this is the one I use in my clinic, and it is available for you to use as well, as long as you acknowledge the copyright. And what I stress is that the child should moisturize, have moisturizer applied over the face and body every day, even if the skin is not red or itchy, because we know that when you have eczema, even if it looks normal, when you go onto the microscope, you'll see that there's abnormality in the skin. And so I would recommend always using a moisturizer, even if the skin looks normal, once you know a child has eczema. Then with regards to which moisturizer to use, I have a picture here of a pot and a pump, but I always advise, and you can see in red here, wash hands before applying creams and never put hand in pot. Use clean spoons, or this could be a spatula or disposable popsicle, anything like that. So this needs to be used to the face and body at least twice a day. And then I talk about probably the most important part of eczema management, which is the bathing. So the bathing is, I think, where most of the confusion arises, because the bathing recommendations are different before you have eczema and after you have eczema. So if you are a child who does not have eczema, then the recommendation is not to bathe every day, because you don't want to dry out the skin, and water on its own is drying. But once you have eczema, it is recommended that you have a daily bath. And in that bath, it's important to avoid soap, bath oils, and bubble bath. And it is surprising how many children have bubble bath in their bath, even though their eczema is really severe. Because bubbles essentially mean detergent, and detergent breaks down the skin barrier. Also, bubble baths have got often fragrances and lots of nasty chemicals in them. So the next part is also very important. So I don't recommend just going straight into the water with no non-soap product, because that will dry the skin. So they need to use some form of soap substitute. There are quite a few moisturizers that can be used as a moisturizer and a soap substitute. Then I recommend that they use a bath, not a shower, and they bathe for a maximum of 10 minutes in tepid water, which means a maximum of 32 degrees centigrade. And this is every day. Then, when the skin is red or itchy, you recommend continuing to use the moisturizer plus a flare control ointment applied to the affected areas only. And I would suggest using only topical steroids that are in the form of an ointment rather than cream. The reason for this is that the ointments will have less preservatives and things that could cause a contact allergy, because they have less water content. So different steroids for the face and neck versus the body. Obviously much more mild steroids to the face and neck are required. And then the duration of treatment. And I have a separate eczema plan that I've modified for those that require proactive topical steroid or topical calcineurin inhibitor treatment. In this particular case, this would be for children with mild eczema, where I would be using reactive care, and I would suggest that once the skin is clear for 48 hours, I either use the steroids for 2 more days after the skin has cleared to treat subclinical inflammation, then they go back to just the moisturizer and the non-soap product for washing, and they don't need to use any more anti-inflammatories. For moderate eczema, however, I will go straight to using the topical anti-inflammatories with proactive care. I'll talk about this in a minute later. I also think it's important to recommend parents apply the steroid 15 minutes before or after the moisturizer. And this is because I've often found otherwise they mix them together, and then you don't get the full benefit of the moisturizer and the full benefit of the steroid. Also, the fingertip unit schemata here is very helpful, and I think just letting them know it's the size of 2 adult hands is much easier than giving them a diagram with lots of different parts of the body and how many fingertips to use. Now, the other thing I wanted to talk about is contact allergens. So we know that 75% of moisturizers examined in clinical trials comprise at least one contact allergen, which is potential for causing contact dermatitis. One that I know, for example, is lanolin, which is in lots of different moisturizers. There are many different types of moisturizers that can be used. One of the moisturizers, which is what we are using in the SEAL study, is a trilipid, which has been shown in various studies to have a benefit with regards to standard moisturizers, i.e. in this study, they looked at replacing standard moisturizers with a trilipid cream, and they showed that the SCORAD levels reduced down from over 50 to around 27 to 28. So a dramatic improvement, which started already within 3 weeks of treatment. In addition, this other type of trilipid has been shown to be, at least after a few weeks, 28 days of treatment, non-significantly different to a potent topical steroid called fluticasone propionate cream. So although after day 14 the fluticasone propionate did show a significant improvement The improvement with the episeram was slower, but then reached a non-significant difference between fluticasone thereafter. So it could be a steroid-sparing agent. So what about topical anti-inflammatories? I'm going to talk a little bit about that now. Now, unfortunately, you can't see the bottom of my slide because of the camera, but these are some of the creams that we use and ointments in the UK. So we've got Elecon, Mometazone, Umivate, Fucibet, Betnavate, and you'll recognize many of these types. There are, these are the US potency examples that I'm providing here. These are also internationally recognized. And the mild ones are considered to be class 6 to 7, and they generally are considered the sort of basic steroids that are used for only mild eczema or eczema on the face and neck. But what I would say is that they are impacted by the modality of the topical corticosteroid, such as whether they're a cream or an ointment, because ointments generally have higher potency than creams, and whether they're occluded. So, for example, if you put one of these under a nappy, it's essentially a bit like a wet wrap because you are occluding the steroid. Then moderate class 3 to 5 topical steroids are between 2 and 25% as potent as the mild topical steroids, and that's because there's a really wide range in potency between these different classes of steroid. You can see here one of the impacts of modality. So mometazone furoate cream is considered a moderate steroid. So Elecon cream is a moderate steroid, and in the UK you can buy this over the counter. But mometazone furoate ointment, or Elecon ointment, is a potent steroid, and so this can only be bought with a prescription in the UK. And this would be considered a class 2 potency, and this can be between 50 and 100 times stronger than mild topical steroids. And then finally, the very potent one, Dermavate, or class 1, that is 600 times more potent than the mild topical steroids. So there's a huge variety and duplication and enhancement of potency going up to these very potent topical steroids. Now, these are the guidelines that I contributed towards for Europe, which are very interesting because they are guidelines that are essentially alive and are constantly changing with the evidence that evolves, which I think is very important because there's so many new treatments coming out for eczema. I think it's really helpful to just go through this because it is very similar to many international guidelines using stepped care. The first, baseline therapy, is the basics, which I think are often done incorrectly. So enough emollients applied in the right way, avoidance of allergens in sensitized patients, and educational programs to make sure that parents are applying the creams correctly, bathing the babies and children correctly. And then you have the mild eczema where you continue the baseline therapy and you use reactive topical corticosteroids or topical calcineurin inhibitors. The dark green boxes are the ones where we believe all informed people would make this choice. The light green ones are the one where most informed people would make that choice, but a substantial number would not. And that's what we've got for the wet wraps here. Then in moderate eczema, the recommendation is to go straight in for proactive topical steroids or calcineurin inhibitors. And that means using the anti-inflammatory for 1 to 2 weeks to control the eczema flare, and then thereafter using it twice weekly, usually for around 16 weeks, to prevent the flare coming back and also to treat subclinical inflammation. And in the SEAL study that we're running, we are using this approach, postulating that by treating subclinical inflammation and reducing eczema flares, we can prevent food allergy. Psychosomatic counselling also is dark green, and then we've got some ultraviolet therapy, which is in the light green. And then when it comes to severe eczema, we've got in dark green the cyclosporin, dupilumab, and then we have one that has a little bit less data in it, but is up and coming, called upadacitinib. Azathioprine and methotrexate are also there, but they're in the lighter green version. So the next thing I wanted to talk to you about with regards to topical steroids was the relative absorption. Given that I had discussed the various classes of topical steroids, I wanted to share with you some really interesting data that showed the relative absorption of hydrocortisone depending on where you were placing the hydrocortisone equivalent. So the forearm, the ventral or dorsal aspect of the forearm is at the number 1, and then we compare different areas of the body. So the scalp is 3.5, the axilla 3.6, the forehead 6, the jaw angle, which is interesting, 13, so quite high. But what's really high, and apologies you can't see underneath my picture, but the genitals and around the eyelid are 42 times what is absorbed in the forearm. So I generally don't use any topical steroids on the genitals or on the area around the eyelids. For this, I would go straight to calcineurin inhibitors. I think it's also interesting to look at the other aspects of pore absorption. So, for example, the sole of the foot, the lateral ankle and the palm, which is why often you need more potent topical steroids to treat this area of the body. So what is reactive management and proactive management? I like this schema because it shows that with reactive treatment, you never really get to the normal skin level. You're always in subclinical inflammation. And we know that with subclinical inflammation, you're driving that Th2 milieu, and then you've got the opportunity for food allergens to present themselves to the skin, and in that Th2 milieu for the antigen presenting cells to transport that to the lymph nodes and interact with your B and T cells, promoting allergy. In proactive management, what you've got is a flare which then is controlled, and then you have proactive topical therapy, which then keeps the skin in the normal skin area, and thus reduces subclinical inflammation, and we would hope reduces that Th2 milieu in the skin. Now, in terms of the safety of proactive versus reactive topical steroids, I wanted to go through some of the data. Now, we know that in a Cochrane review, which was in 7 studies of over 1,000 children, they found that fluticasone propionate cream prevented relapse by 50% when used twice weekly, and this was in children down to 3 months of age. And then they did another study in the UK, and they found that children that were having fluticasone propionate were 8 times less likely to have an eczema relapse if they were using this treatment. And this is why we use the fluticasone propionate in the SEAL study. What they also looked at was whether there was any skin thinning, and this was part of the Cochrane review, which showed that there was no skin thinning when there was proactive topical steroid use in over 1,000 children down to the age of 3 months. They also showed that there was no cutaneous atrophy by using the same moderately potent topical steroid down to 3 months, and there was no adrenal suppression in 44 children aged between 3 months and 6 years with twice daily moderately potent topical steroid cream for up to 4 weeks. This is a case report which I think is really important for us to see because it highlights the importance of communication and the importance of having a written eczema plan. So this is a case report of a little Indian boy who had 6 months of treatments with Fucibet on the neck. And if you remember, that was one of the areas of the jawline that you had increased steroid absorption. So between the ages of 2 and 6 months of age, he had Fucibet applied 2 to 3 times a day, which is a potent steroid. Now, the parents, unfortunately, were unaware of the possible side effects because of language difficulties. And when the child was eventually admitted to hospital, they found that there were changes of the face and body consistent with steroid absorption and also suppression of the adrenal glands. These are some of the other forms of steroid side effects that can occur. I want to particularly focus on the issue with glaucoma when the steroids are used around the eye. And so again, I would suggest not using topical steroids around the eye, but using topical calcineurin inhibitors. Of note, the topical calcineurin inhibitors cannot be used on infected skin. And then there are distant side effects such as Cushing's, adrenal suppression, slowing of linear growth. And this was actually found recently in the Patchy study, where they used all over potent topical steroids in young infants with mild eczema to try to prevent food allergy, but it also resulted in reduction in weight and in length in the intervention group. More local side effects you can see here: stretch marks, skin thinning, bruising, localized pustular psoriasis, and then you can also get something called corticosteroid dependence, or topical steroid withdrawal syndrome, which I'll talk about. And then again, also it can increase the risk of various types of infections, and so this is something that also needs to be monitored. In terms of what I see in my clinic, the most common side effect of using topical steroids is perioral dermatitis. And these are some pictures in different age groups that you can then use as a basis for your practice. So generally this presents as multiple small papules around the mouth, nose and eyes. And this can affect children as young as 3 months of age, but the average age of children in this study was 6.5 years of age. And it was most commonly seen with long-term topical steroids on the face. And if you see this, then what you need to do is switch to a topical calcineurin inhibitor and stop topical steroids. There are many parents that are concerned about topical steroid withdrawal reactions or topical steroid addiction, because there is a very strong social media presence of this, with patients who understandably are extremely upset and disappointed when they have ended up getting this condition. And what has happened is, because of that, even parents of young children who are using only 1% hydrocortisone for a few days are concerned about this condition. So I think it's very important that you address this head on with the family and don't leave them worrying about it without having discussed it with you. So we know that topical steroid withdrawal syndrome is caused when there are long-term continuous use of topical steroids, particularly those of moderate to high potency. And what happens is that you get a rebound flare after stopping treatment, and this can be very nasty. If you use topical steroids for suitable conditions where there are short periods of time of breaks or interval symptoms of breaks, then even in an extended period, this has not been described. In a systematic review of 34 studies with over 1,200 patients who with reported steroid withdrawal syndrome, over 85% reported that they had used topical steroids for over 12 months, and all the patients with topical steroid withdrawal syndrome had been using the steroids daily, and very few of these individuals were under 3 years of age. This is a really fantastic systematic review and network meta-analysis of randomized trials, which was published in 2023. And in this, they took over 43,000 participants, both pediatric and adult, with mild to moderate eczema. They looked at 219 randomized controlled trials, and they looked at a huge number of different therapies, including wet traps, all the different strength topical corticosteroids, the 2 strengths of tacrolimus or protopic, the pimecrolimus or Elidel cream, topical antibiotics, prescription moisturizer devices, and then some of the newer JAK kinase inhibitors such as ruxolitinib, and also PDE4 inhibitors such as crisaborole. They looked at various different factors, including gaining control of eczema, maintaining eczema control, once or twice daily administration, and they looked at the outcomes of disease severity, sleep disturbance, eczema flares, adverse events, itch severity, and quality of life. They also incorporated patient-important outcomes, which was clinician-reported AD severity, patient-reported, including proxy-reported severity of AD for children, itch severity, sleep disturbance, quality of life, long-term control with number of patients experiencing AD flares, adverse events, including those leading to discontinuation, and skin infections. Okay, so if you look at this schema, you can see that in dark green, these are the ones with the high to moderate certainty evidence that have among the most effective benefits. So for the JAK inhibitors, we've got mainly quality of life for delgocitinib, but also mainly adverse events and discontinuation due to these. For the PDE4 inhibitors, such as crisaborole, you have not much going on there in terms of significant benefit. Some intermediate inferior effectiveness and no difference from control. So not a lot of evidence for these. The topical calcineurin inhibitors, there's a lot of good dark blue evidence here, for example, for itch, for the high-dose tacrolimus, for sleep disturbance, for pimecrolimus or Elidel, and for preventing atopic AD flares for all three of the creams or ointments. For topical steroids, you've got a mishmash of dark green with the potent group 1 steroids reducing eczema severity. All four of the moderate to potent steroids improving itch, some improving atopic dermatitis flare, some adverse events, and discontinuation due to adverse events mostly in the very potent group or group 1. And then for the prescription moisturizers, there was some benefit for atopic dermatitis flares. These are prescription moisturizers such as those containing trilipids. Antibiotics, creams didn't really help. This is a summary of what was shown in the previous schema, which shows that for AD severity, super potent topical steroids were the best. For itch severity, the tacrolimus or protopic high dose was the best, followed by topical steroids between groups 2 and 5. Preventing AD flares was topical steroid group 5, which is lower mid potency, which includes fluticasone propionate, which is where a lot of this evidence has been found with proactive topical steroid use. But also topical tacrolimus and pimecrolimus cream were beneficial for preventing AD flares. One of the things that I want to mention is that for patient-important outcomes, the pimecrolimus cream improved 6 out of 7. And they were most effective for sleep disturbance and preventing AD flares. So I want to focus a little on topical calcineurin inhibitors now. There's quite a lot of evidence now which shows that it prolongs the interval between flares when used particularly proactively, and has also been shown to improve barrier disruption, which I think is important given that topical steroids could be considered to not improve barrier disruption as much given the fact that they have skin thinning and cutaneous atrophy side effects. The pimecrolimus 1% cream is licensed from 3 months of age in the UK and Canada, and it is not licensed in many other countries from 3 months, but it is licensed from 2 years of age in almost all other countries, and use under 2 years of age is very common. There was a recent task force by the American Academy and the American College which looked at a systematic review of 3.4 million patients across 110 studies, and they showed that calcineurin inhibitors for atopic dermatitis did not increase the risk of any cancer, which was of moderate to certainty evidence. And two particularly nice studies looked at the efficacy and safety of pimecrolimus in almost 2,500 infants with mild to moderate AD. And then there was a long 10-year study in children who started protopic 0.03% ointment before 2 years of age and showed no increased risk of cancer. So I now reassure my parents that they do not need to worry about using topical calcineurin inhibitors with regards to cancer. But what I do say to them is that they cannot use topical calcineurin inhibitors on infected skin, and they cannot, and with regards to eczema, all children with eczema need to use factor 50 suntan lotion when exposed to sunlight because their skin is sensitive anyway to ultraviolet light. So moving on to microbial therapies. So I think I talked previously about the fact that topical antibiotics were not helpful and that you have an overabundance of Staph aureus that builds on the skin with reduction in commensals and diversity of other skin flora. These are the types of reduction in bacteria that are good for the skin. So bifidobacteria goes down, Bacteroides goes down, and when this happens, then your short chain fatty acids go down and your Tregs go down. Also, the F. prausnitzii and the lactobacillus go down, which then enable Th2 cytokines. Then you get an increase in Staph aureus, which has also been shown to lead to intestinal permeability. Increase in Clostridium difficile, which leads to a reduction in Tregs. Increase in E. coli with LPS, and then enterobacteria leading to Th2 increase. So how can we address microbial diversity and dysbiosis in children before the onset of eczema? We've talked about this before with regards to lack of antimicrobial peptide, and we know that the Staph aureus particularly causes issues with not just eczema severity, but also predisposition towards food allergy. So this is just a schema of what happens when you get Staph aureus on the skin. You develop this biofilm, which then has superantigens and leads to an atopic dermatitis flare, and is postulated to then present the food allergens in a more Th2 environment to the antigen presenting cells, B and T cells, therefore leading to allergy. These are some of the topical probiotics that have been used. They're called sort of gatekeepers to prevent the growth of Staph aureus. And the one that has a lot of information is the Roseomonas mucosa. So this is being looked at, and this was a systematic review which showed that there was a significant improvement in SCORAD, in EASY, and also a reduction in Staph aureus colonizing units. Mixed results for TUL, but there were no adverse side effects in 8 studies, and in 2 studies there was just mild local skin irritation. So I think this is definitely an area of interest, and I imagine there will be some products on the market quite soon for this. There are many other ways to target the microbiome, not just on the skin, but obviously on the gut as well, now that we know about the translocation between the skin and the gut. And these are some of the other microbial manipulations that are under investigation. How would probiotics in the gut potentially work for eczema on the skin and food allergy, of course? So there's many hypotheses, but this particular article looked at oral probiotics leading to maturation of dendritic cells, increased Tregs in the mesenteric lymph nodes, suppression of Th2 and Th17 mediated inflammatory responses in the skin, reducing TSLP expression in the skin, and improving barrier function not only in the gut but also in the skin. These are some of the benefits that have been postulated with certain lactobacilli. But in general, what I would say is that overall, the only organization internationally for allergy that recommends probiotics is the WAO. This has limited support for probiotics for the prevention of eczema in high-risk children by giving pregnant women in their final trimester plus breastfeeding women or infants probiotics. And it's very important that these are given both in the final trimester because of epigenetic changes, and then in the first few at least months of life whilst breastfeeding, or in formula if the child is not breastfeeding. However, the grade of certainty was low or very low due to the risk of bias, inconsistency and imprecision of results, and indirectness of available research. This was now done quite a long time ago, so I'm hoping that there'll be some more data that is provided on this. This is a very nice study that looked at just one type of probiotic in combination potentially with other probiotics, but it was conducted by a commercial company, so it does need to be looked at by independent investigators. However, what they found was that when used both in the perinatal period, i.e. before the child was born and after the child was born, use of this particular probiotic had a risk ratio reduction of eczema of 0.6, which is pretty good. So I think this is an area of interest that needs to be further investigated, and this particular study should be repeated again by non-conflicted investigators. Now I'm going to talk about allergen immunotherapy. I think this is, really nice where you cross between allergy and eczema. Now, a long time ago, there was a systematic review that looked at doing house dust mite immunotherapy for eczema management, and it was a negative result. However, that was several years ago, and since then there have been a lot of new data, and this meta-analysis published in 2023 showed that there was a benefit of favouring AIT when used in children with eczema who were sensitised to house dust mite. So you can see here that for a slit, the relative risk for favouring AIT was 1.45, and for skit it was 1.74 favouring AIT, so overall 1.53 relative improvement of symptoms. And so this is one particular point that they made. So 23 RCTs with almost 2,000 adult and paediatric patients sensitized to house dust mite showed a reduction of 50% in SCORAD and an improvement of a dermatology life quality index by 4 points or more. So the adverse events, however, were much higher in skit, which, as we know, is generally always the case. So 66% with skit versus 41% with placebo, which is pretty high for the placebo. And then for slit, it was 13% for the slit with house dust mite and 8% for the placebo. So something to think about in your patients that have very severe eczema that is not controlled and who are house dust mite allergic. Finally, I'm going to touch on systemic therapies. And this was another study that was done similar to the one that I mentioned before, but this was for systemic treatments rather than biologics. And in here they looked at dupilumab and UV phototherapy and other biologics such as lebrikizumab, but then also immunosuppressants such as azathioprine, cyclosporate, mycophenolate, methotrexate, the JAK2 inhibitors, and then some more investigational treatments. They also assessed both children and adults. This was in over 28,000 participants with eczema severity between moderate and severe. So what did they find? If we go from the top, in terms of the psychostatic and immunosuppressive agents, to be honest, there wasn't that much that was very beneficial. Azathioprine, cyclosporin, methotrexate, mycophenolate, not much was green there. The monoclonal antibodies, the strongest was dupilumab, which is in dark green for sleep disturbance, but also lebrikizumab for sleep disturbance and omalizumab for sleep disturbance. Unfortunately, omalizumab did not fare particularly well. Then for the oral JAK inhibitors, there was quite a lot of dark green, and I do think that this is an area that hopefully will become available to us very quickly in the UK. I know it is available to some people already. This had benefit on all of these different aspects if it was measured. So atopic dermatitis severity, patient-reported AD severity, itch, eczema-related quality of life, atopic dermatitis flares, and so the only problem with the oral JAK inhibitors, the upadacitinib, was that there were some adverse events, but not serious adverse events. And then UV light therapy helped with sleep disturbance, but the other things such as oral corticosteroids and montelukast were not recommended. So yes, so definitely there's some very exciting work ongoing. These guidelines are currently being updated because I'm part of the group. So it'll be interesting to see when they include all the newest data for this study. So I've come to my last few slides where I want to just highlight how to use this information for your patients. So I hope I've stressed enough to you that the verbal advice is only part of the consultation and that written education on the basics of eczema management is vital if you're going to get control of the patient's eczema. Please use free educational resources. This is one of them, but there will be many others that will give the education that parents can access for free online at a time that's convenient to them. Make sure, please, that when you're using an emollient that it's not harmful to the skin, that it doesn't contain something like SLS, which we know is in aqueous cream, but is also in other creams. And it's important to make sure that there's no olive oil in this emollient, because that has been shown to impede the lamellar structure formation of the skin, and also to make sure that there are no other contact allergens such as lanolin. I would suggest using proactive topical therapies immediately in moderate eczema, because what I've seen happen is that you see them in clinic, and then unless you explain to them the importance of using this straight away, they will all use the steroids until the eczema gets better, then stop it, then the eczema flares again, and then there'll be a space of several weeks potentially until they see you again, during which time the eczema is uncontrolled, causing lots of issues for the skin, psychological issues, and also potentially increasing the risk of developing immediate food allergies. The next part is about educating parents and patients about the use of topical steroids and directly addressing their concerns, as they may otherwise go away and just not use the topical steroids, including topical steroid withdrawal syndrome. I would say that topical calcineurin inhibitors now really do provide good alternative treatments, given all the long-term safety data, and I would be starting these much earlier on in treatment for atopic dermatitis. I think that microbial therapies using these good bacteria as gatekeepers for Staph aureus has some interesting data, and also using house dust mite allergen immunotherapy in AD in children who are house dust mite allergic also has some interesting evolving evidence. Systemic therapies I've touched on briefly. The biologics generally have a very high efficacy, but also higher adverse events. And I think the JAK inhibitors certainly are very interesting to follow, given that they had very good efficacy, but they also had some downsides with adverse events. So I'd like to thank many people that work with me together at King's College London, and all the different collaborators on the SEAL study, and to the NIH for their generous funding for the SEAL study, and to Northwestern for the collaboration work that we do together. Thank you very much for your attention. I'm very happy to take any questions.